Hello beautiful people, welcome back to my channel. To those of you who are new here, I'm Ashil and I'm back with another video. I know there has been a lag, but I'm back. I'm back. So today's video, we're going to discuss the differences between nursing in the Caribbean, particularly St. Lucia, because that's where I'm from, and nursing in the US. I've just moved to the US, for those of you who do not know, and of course some changes I did expect, but some very new to me. So I'm sure this would be helpful to those of you who are looking to move across or just interested in the difference. If you are, please stay tuned. Let's jump right into the video.
I'm looking down from up in the sky. I don't like it.
So this is going to be a short video. Like I said, just highlighting the differences. I don't want to be too long, probably about 15 minutes. So let's jump right in. So the very first change that I had to get used to, like I was not prepared for that, nobody prepared me for that, was the fact that you only get 30 minutes for break. 30 on a 12-hour shift. So in St. Lucia, I worked 12-hour shifts and I was pretty much mainly on nights. Right now I am solely on the night shift, which means that I work 12 hours for 3 nights, sometimes 4 for the week. So imagine me coming from St. Lucia, where we were entitled to 2 hours of rest on a 12-hour shift, coming to the US to get 30 minutes of break. Yes. So like I said, it was quite a shock, quite an adjustment, because I mean, even in St. Lucia, there were shifts which were so busy that you would not be able to get a full 2-hour rest. Sometimes you don't get any rest at all. But hardly ever would you work 3 shifts in a week or 2 shifts in a week and not get any rest at all on a night shift. So even if you miss a night, you would make up for it on another night. But here, no. You worked your 12 hours, the 30 minutes that you are allotted for break. Well, they call it lunch. I know it's weird because it's in the middle of the night. But it really, you cannot do anything during that time apart from probably get something to munch on. The good thing is that you can munch on anything throughout the shift, but that specific time where you just take a breather away from the unit, away from the babies, away from everything, I feel like it's not enough. But I wasn't ready. I really was not ready. So that is one difference. Another difference is the uniform. So in St. Lucia, we wore what you call muftis. So this is pretty much just regular clothing to work. So we were not allowed, that was specific for our unit, especially since we dealt with babies who had probably compromised immune systems or just developing immune systems. I mean, we can't compare a baby's immune system to ours. So just to avoid all the germs and everything that you would probably touch and your clothes would rub on your way to work, we wore muftis or regular clothing to work. Once we got to work, we would change into our scrubs and of course work for that shift, and then once our shift was over, we'd change back into our muftis and leave. However, here you go to work as is. So you go to work with your scrubs, and barely anybody wears scrubs, like full scrubs. Our uniform for the entire hospital is mainly t-shirts, especially for the NICU. And again, I work at a pediatric hospital, so we are kid friendly, children friendly. So there are a lot of persons wearing shirts with just cartoon characters, characters which children love, and just to make it, I guess, a more children friendly environment, and just to take out the seriousness of the uniform when coming to provide care for the patients. So mainly what you will see are nurses wearing just a regular t-shirt. Most of them wear the children's branded t-shirts, like the hospital branded t-shirts, sorry. And a lot of them to wear just the character tees and your scrub pants, of course. So this was an adjustment because, you know, home, especially with the other units, I mean, I was assigned to the NICU, so we wore a specific color. We wore peach to work, peach scrubs, pattern scrubs, you know. But nurses, especially in the Caribbean, you associate with white. So white scrubs, white nursing uniforms. Hair, no. Pretty much mainly scrubs, and like I said, t-shirts for us. So that was just a little strange, but I mean, I can definitely get used to that. Another difference was the clocking in system. So the clocking in system in St. Lucia would pretty much be pen and paper. So you manually write the time you get into work, you check your time, manually you write in your time, and when you leave, you write the time that you left. Now, y'all know I always talk about my memory. So, you know, 3 out of 4 times I would not remember to clock in or clock out. Most times, not most times, sometimes I would remember to clock in, most times I would not clock out. So here, sis, if you don't clock in, you don't get paid. You don't get paid because you need to show that you are at work. So the clock-in system, you call a specific number, it's automated, so it knows that you're calling for you to clock in. It automatically registers the time that you clock in, and of course you do the same thing when you clock out. So I literally had to force myself. I mean, you know, once your incentive is money, then you're on the ball. But honestly, I had to remind myself to clock in or clock out. But the good thing though is that there is an online system where you can manually clock in, like your time that you came into work, if you do miss that clock in period. But yes, another change or another difference was the staff distribution or staff responsibility, I should say. So I'm coming from the Caribbean, coming from St. Lucia, where it's pretty much nurses and doctors. Nurses and doctors, your ward managers. Pretty much that is what, and of course your interns here and there. Your nurses are responsible for setting up your ventilators, placing baby on the ventilators. I mean, of course, the doctors are there to help. The doctors are the ones intubating babies, you know, just making sure that the ventilator settings are correct. But it's pretty much us nurses setting up the vents, putting it in place, ensuring that, you know, there are tight seals where everything is supposed to have been sealed. That is what I know. Here, the only thing you're allowed to touch on the people's ventilator is the FiO2. So the only thing you can adjust is your O2. You don't set up a ventilator. You do not touch a ventilator unless you're adjusting the O2. You have nothing to do. There are respiratory therapists who are trained in specifically to provide respiratory support. So this is their forte. This is their area. They deal anything respiratory. If a baby is desaturating, and of course I mean, a baby is desaturating, you're a nurse, you know what to do. But they still run across to ensure that everything is fine. They're always on the unit. So there is always a respiratory therapist on the unit. Also, neonatal nurse practitioners. I have never seen a neonatal nurse practitioner in St. Lucia. However, here there are many neonatal nurse practitioners, and they are, of course, if you're a nurse, you know what a nurse practitioner is. So they are pretty much just specialized in neonatology. So they come around, do their rounds, prescribe what needs to be prescribed, discontinue what needs to be discontinued. It's a totally different atmosphere. That is not something I'm used to. I'm used to the doctor prescribing everything, discontinuing everything. So it was a nice change to see that a nurse being in that position, and it was just a motivating thing to see. But I'm here for it. I'm here for it. Y'all know I forget everything, so I have the things written down because, you know. Also, in St. Lucia, our doctors would be responsible for sighting babies, so getting IV accesses, peripheral IV accesses. They would be the ones to draw blood if baby needed to have any blood gas taken or any blood works done. The doctors would be the ones to retrieve the blood. Here, however, the nurses are the ones who take blood from babies. So the nurses, they mainly do heel sticks, but you would be the one to take any blood that is needed from the CVLs, which we don't really have. The PICC lines, these things we barely had in St. Lucia. They did have them, but barely would you see especially a CVL, which is a central venous line. Barely would you ever see that. So the nurses are the ones to take blood from the babies. However, it gets interesting. However, if for some reason this baby is what we call a hard stick, meaning that it's very difficult to get blood from them, probably because we've exhausted all of their venous accesses or they have difficult veins to access, then we have a vascular access team. So there are persons who are trained in putting accesses. Do you hear that? Like, there are people who are trained to put accesses. So if your baby is a hard stick, you put in an order for vascular access and they come right up to the unit with their ultrasounds and everything, and it's really a breath of fresh air, because imagine having to stick a baby so many times and not knowing what's happening, the veins keep blowing. So that is pretty much a plus. Also, the nurse-patient ratio. So specific to our unit, I'm not sure how it is on the other units, but specific to our unit, you are only allowed 1 to 3 babies. So the nurse-patient ratio cannot exceed 1 to 3. There is no time at all where you will have 4 babies or more. In St. Lucia, that was pretty much our nurse to patient ratio. However, you know, there are staffing issues that would have caused the problem. So there were times where you have 5, 6 babies. I mean, it wasn't often, but it did happen. But here, you cannot get 4, 5, 6 babies. It's not going to happen. So that was a good thing, because I mean, it is good to have 3 babies where you can manage your babies. You know what's happening with each of your babies. You're on top of the game. You don't have to stretch yourself too thin. So that is definitely a plus. Another difference is the medication administration. So with St. Lucia, you know, you get all your medication. There is a medication room where all your medication is stored. You have your DDA, which is where your high alert drugs are, so your narcotics, etc. These would be stored in the DDA. One person has the DDA key. If you need anything from the DDA, you would have to hunt that person down to get that for you. You would have to sign the dual sign off, where 2 persons would have to sign for that DDA drug. You go to your medication room. If it's just a regular drug, you pull up your drug, you administer your drug. You of course do your 5 rights, administer your drug. Here, the drug comes up from pharmacy prepackaged. So if you are given 1 milligram of an antibiotic, it comes up packaged 1 milligram in a syringe, labeled baby's name, the medication record, the medical record number, the barcode, and I'll tell you about the barcode in a bit. Everything is on the label. So all you do, again, you still practice your 5 rights of medication administration and ensure that everything matches off with baby's ID band as well as the medication that is in there. Like I said, I would talk about the scanning. So before you give that medication, you must scan. So there's a literal scanner. You scan the patient's ID band. You scan the medication to make sure that they match. If for whatever reason you're probably overwhelmed or your head is not there, you scan a wrong patient's band or medication, it will alert you, hey, are you sure the patient you wanted to scan, because this is not, this medication, this medical record number and this medication do not match. So this was a plus because God knows, especially if you have a baby, we used to call them, if you have a baby that has a whole pharmacy of medication, meaning that they have a lot of medication to give, you spend so much time pulling up medication, and you don't have medication once on a shift, you have sometimes twice and 3 times on a shift. So you end up spending so much time in a medication room pulling up meds, and which takes away from your one-on-one patient time. I was so pleased to have this done because I mean, I would love to pull up my own medication and ensure that I'm giving what is in, but it is a breath of fresh air knowing that you don't have all of this. So your medication, the time that is due is on there, everything is on there. So you just pull up, you ensure that your medication matches your patient and everything matches, and you administer your medication with no issues. With your higher load drugs, the same would apply. You would need somebody to sign off on your drugs, just as in St. Lucia. You would need another nurse to ensure that you did take the medication and you gave it. Same thing applies. However, in addition to ensuring that you do have a dual sign-off, which is just a fancy name for a double check, the nurse who double checks your medication would need to ensure that it is wasted as well. So in the computer, there is a specific part which has a waste for your medication. So it depends on the amount of drug that you have to administer. It automatically calculates how much of the drug is supposed to be wasted. So the nurse has to ensure that you have whatever it is you have in your syringe, and whatever is in the bottle is pulled up, wasted in a sink, in a tissue, in something, and that it is discarded. Reason for not throwing an entire ampule or an entire syringe with medication in the sharps container is to ensure that nobody with an addiction or who are on the lookout for these drugs have easy access to just push their hand or something in the sharps container to obtain that medication after you've thrown it out. So it's advised to waste it down the sink, waste it in a tissue or something, and then discard. So the next thing is documentation. Now, that was my biggest issue in St. Lucia. Honestly, that was my biggest issue, because sometimes you have like 4 babies, and they're heavy babies. Or you have 2 heavy babies, meaning that not physically heavy, but the amount of work you have to do for them is a lot, right? So with you having to physically carry out your tasks for that baby, you still have to document every single thing that you do, right? Now, the documentation takes time, because NICU documentation, like I'm sure I've said in a previous video, is very detailed. So it's based on the systems, and you go down the line, detailed documentation. So it was very time consuming, especially if you had more than 3 babies. Very time consuming. So with hair, everything documentation wise is on the computer. Everything. So everything you could have under a system is there on the computer. All you would have to do is choose so for example, you have a baby, the baby is icteric, jaundiced, the baby has a peripheral IV access on the left hand, the baby probably has let's say a CVL as well, so a central venous line. Going into your documentation, you would pick baby is pink, so it has all the options: pink, jaundice, pale, everything, mottled, everything. So you click pink, jaundiced. Then it has, for the CVL, there's literally a drawing of a doll or baby doll, which has any point that you would have an insertion, an IV insertion for a baby. So if baby has a CVL, you just click that CVL, where exactly it's located, what kind of line it is, etc., etc. So it makes your work much easier, seeing that everything is already there. You literally just have to click, 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 click. Now I love it. However, it is something to get used to, because there are certain things that you must document, certain things that you must document on your initial taking over of your baby, and that you probably don't have to document later on in a shift. So it's something that you have to remember, every little thing that you have to do. So initially, for a nurse coming in, it may be a little time consuming as well, just because you have to ensure that you're not missing anything. You're on your P's and Q's, dotting your I's, crossing your T's. But it is definitely much less time consuming than having to physically document every detail of your shift, which I'm sure especially my NICU nurses would know is a pain. It's really a pain. So that was something that I loved. That is something that I will definitely be getting used to. Also, specifically to the night shift. So of course there are tasks that you would do in the day shift as opposed to tasks that you would do in the night shift. I am oriented solely on nights just because I'm only going to be working night shifts. So on a night shift, you would have line changes. If a baby is getting TPN, so total parental nutrition, baby's getting lipids, you would have to change that line every single night. We ensuring that we're remaining CLABSI free, so you would have to change that line every single night. Whereas I have seen lipids being given home in St. Lucia, but I've never seen TPN being given. So these are things that are rare. They don't usually happen. You would have your regular clear IV fluids. Clear IV fluids, anything like dextrose, normal saline, here now. Oh, we say saline, but here is saline. So these would be changed. These lines would be changed on a day shift. However, anything total parental nutrition, anything lipid wise, these would have to be changed on a night shift. So another thing which has to be scanned are your feeds, especially if it's breast milk. These would have to be scanned, automatically enters the database. Even if you're fortifying milk, you would need to do the very same thing, especially with fortification. Nothing really changed in terms of fortifying. However, in St. Lucia, if you're fortifying, you would know how much of for example, if we're using formula to fortify breast milk, you would know how much of the formula to put into the breast milk. It would tell you. We'd do our research, you would know how much to fortify to get different amount of calories. However, with the US, they are little snappies which are pre-packaged. So they send up the snappies up and they let you know how much breast milk is supposed to be mixed in. So you pour your breast milk, open your little snappy, pour it, and your milk is fortified. So it's the same thing, it's just that you are sent your pre-packaged formula or whatever fortifier that is being used. And last but not least, coding. So if a baby is coding in St. Lucia, we are all there or hands-on. Everybody has something to do. Everybody knows what they're doing. Whether you're documenting, whether you are helping the doctors resuscitate, whatever it is. Here, there is a literal code team. So if your baby is coding, heart rate dropping, everything going haywire, there is a button that you press which calls the code team. Now, this happens for the entire hospital. Any part of the hospital, the code team would respond to that request. So, like I said, I have just been up here for a little while and I'm just taking in the changes and just trying to adapt and everything. And I felt that, especially for my nurses who are thinking of coming up to the US, at least you would know what to expect. I'm not saying that what I'm saying here is across the board for every single hospital, but at least I'm sure that one thing that I say, you may be able to relate if you're up here already, or you will see it happen at your hospital if you are on your way to the US. So guys, as usual, if you do like what you see here, please like, share, and subscribe. do subscribe, tell a friend to subscribe to my channel. And of course, you can stalk me on Instagram. It's Achille Antoine. Do stay tuned for the next video.
Girls like me.